Hello, everyone. My name is Mindy Christianson. I'm the practice director at the Cleveland Clinic Fertility Center and the section head of reproductive endocrinology and infertility. And we want to thank you for joining us today for the Oncofertility Consortium webinar. The webinar today will last around 45 minutes, and then we'll have 15 minutes of questions and answers. Please, during the presentation, keep your mic muted and your camera off throughout the webinar to avoid background noise and distraction. If you have a question, please post it in the chat. We'll then open the discussion at the end of the webinar with the ability to turn on your mic and camera so you can ask questions. This webinar will also be recorded and uploaded afterwards to our Oncofertility Consortium YouTube channel. So today we are very excited to have Dr. Sherman Silber, who does not really need an introduction, but we will introduce him because we're so happy to have him here. He is a renowned pioneer in microsurgery and infertility, and he's considered one of the world's leading authorities in the field of infertility and fertility preservation. For over 43 years, Dr. Silber has originally developed most of the popular fertility treatments around the world, especially involving fertility preservation and ovarian tissue cryopreservation. So we're really excited to have him today to speak about fertility preservation in patients who never had fertility preservation.
Well, thank you very much, Mindy. I'm really honored to be with you and Mahmoud and Oncofertility. I'm just purposely talking about some things that are out of the box, but I think important. And I have a longer talk than there's time for, and I'm not going to really speak fast in order to get it all in, but we can always continue it at some later date. But I purposely made this provocative title, but that's really what we're finding. And oh, let me see, I've got to control it this way. Yeah. And so I want to say that we've collaborated with Katsuhiko Hayashi for 10 years on a lot of this work because he's done it all in the mouse for in vitro gametogenesis. But a lot of that still has practical applications without going to in vitro gametogenesis. And with Dan Brennan, who's the head of renal transplantation at Johns Hopkins, and Rowena DeSantos and Annabelle Mello, renal transplantation people at Barnes. They were all part of the same group until Dan went to Johns Hopkins. And we've been talking about this for really the last 15 years together, how we can get a immunosuppression regimen that would be really usable and safe for what is clearly not a life-saving procedure. And we have permission from all the patients that you'll see here. It's kind of nice to show the real people. And this is a stellar early patient of ours. Name was Stevens, Kate Stevens. And she had leukemia when she was just 5 years old, had a bone marrow transplant, and they were told that she had no more eggs left whatsoever with undetectable AMH. So it's acute myelocytic leukemia. She was 5 years old, and here you can see all of the drugs that she was put on for chemotherapy. And as a teenager and a young adulthood, she had no periods and undetectable AMH. And she came from Sloan Kettering that I should say we have a very good and a close collaboration with Sloan Kettering. So now she's 23 years old, and that diagnosis was acute myelocytic leukemia, completely in remission, and AMH undetectable. And yet we wound up doing oocyte freezes with minimal stimulation or natural cycle over the course from January 23 till January 25 over the course of 2 years. And we have 7 very good metaphase 2 eggs from a woman who is 21 to 23 years of age, so they're good quality eggs. I'll go into that a little bit now, and I'll just show you the details of the first stimulation protocol in January. Very, very mild stimulation. You don't want to try to, I'm going to say this very strongly, and I'll be able to give data for this in many different ways, that your first your first gut reaction is to give her a huge dose of gonadotropin to try to squeeze out whatever eggs might possibly be there. But that is absolutely the opposite of what you want to do. You want to give a very, very, very mild dose to try to squeeze out the eggs. And I'll explain to you as this lecture goes on about why we anticipate that there are some eggs frozen in time, really, and not not recruited in ovaries that are virtually empty, and they seem to be empty. And there was our first aspiration of a follicle that formed from this mild stimulation that, like, if you saw it, it was 50 milligrams of clomid a day and 150 of follistim every other day. And there's that first egg. Now, when we got that egg out of Kate, who everybody thought she had no eggs, her parents were very concerned and helpful people. And Kate is a brilliant student at Harvard. And what we cared about her, such a sweet young woman. And I have to say, you can talk to all my colleagues. When the embryologist said, "We've got an egg, a metaphase 2 egg," everybody in the afternoon jumped. She was asleep. Everybody jumped up with joy. Everybody was so thrilled. We were dancing around in the operating room. We were so excited. And we remained that way. And so then she came back again 3 months later in April. And again, you see 50 milligrams of clomid a day, 150 of follistim every day, 2.2 follicle. And then we also got another good oocyte. Now, the oval shape of the zona pellucida never really worries us at all. It's a good oocyte, as you can see. And then she came back again in August of the same year, and we got nothing. And she came back again in January of 2024, and again, we got nothing. And she came back then in March of 2024, and as you can see, she's going to day 20, and there's nothing. Uh, and then later in March, we just kept on going, and again, there was nothing. But in June of 2024, with no stimulation, basically, because it just came up naturally, we found a 2.2 follicle, we aspirated it, and we got a second egg. Let's see. Oh, we don't have a picture of that egg. Okay. And then in July, and that was a mistake on our part. Then in July 2024, very, very early with just clomid and a little follistim on day 3. And we had a follicle and a good estrogen level. We aspirated and we found another good egg. So that's her second good egg. And then she came back in September of 2024. We got 2 eggs, believe it or not, very early in the cycle with this very, very mild stimulation. Now the polar body is, you can see at 12 o'clock. And the second egg, it's hard to see the polar body. It's up near 12:30, but you can't see it because we don't have so when I took this picture in the right position, but we know that it was there. And we'll just keep going through this, and you'll see here now we're already up to January of this year, and we got 2 more good eggs. Again, these are both metaphase 2, but on the top one, you can't see it as easily because we didn't bother to position it in the best possible way. So there she is, despite undetectable AMH between the ages of 21 and 23. After a bone marrow transplant for leukemia when she was a baby, we were able to get 7 frozen eggs. So this is spectacular. I just wanted to wake everybody up with this. And the real issue is control of ovarian longevity, and that kind of explains it. And I'll go through, this is a graph that Teramoto did with close to 25,000 patients in Japan by age. These were patients coming to the infertility clinic, and huge numbers. They were doing like 12,000 cycles a year at that time, more than anybody else in the world. And you can see it's very clear. You've got a drop in AMH according to years and this is average I don't remember what the standard deviation was, but this is the mean AMH going down according to years. And then when we look at ovarian tissue that we've dissected in order to do ovarian tissue freezing, if you look closely, even under the operating microscope, you don't need pathology. You can see that the most dense stroma is on the outside, less dense as you go toward the inside, and least dense as you're getting close to the medulla on the inside. So there is a gradual decrease in tissue density and tissue pressure as you go from outside to inside. Now, the other piece of evidence for tissue pressure is just that with all of our ovary transplants, every single one of them, whether an allotransplant or a fresh identical twin case or a frozen ovary tissue allotransplant, and we've done many of those, and we already have 31 babies from this, just in one center alone. And we always see the same thing with their recovery after the transplant. There's a decline in FSH over the course, probably by about 4 to 5 months. And at the same time, the FSH goes down, the AMH goes way up. And then after about 4 to 8 months, it comes down again and stays at a very low level. And these graphs last for 8 to 12 years with AMHs that are 0.2 at a very, very, very low level. So what is the explanation for that? We'll get to that. But the most important thing is there's massive primordial follicle recruitment when you do the ovary tissue transplant due to a sudden decrease in stromal tissue pressure, which is the mechanism of oocyte arrest. And you can see what controls the recruitment of follicles in adults from the resting phase. Well, there's a gradual release from the fibrous cortex, just like in the fetus, and there's a more dense cortex, more distally, and as you go more towards the medulla, it's a milder cortex, and I'll show you what that really does. Sorry. So Hayashi, when he saw that, he decided to do a really phenomenal in vitro experiment, and he incubated artificially produced eggs. You can't do this with eggs you get from ovarian tissue because primordial follicles are locked. And what is it that locks them is the question. And the reason they're locked is so that the little fetal girl doesn't run out of eggs before she's born. They have to get locked in some way. And they're locked in the tougher tissue of the outer cortex. In any event, so he was able to take artificially created eggs from his work with stem cells transformed into mature eggs, and he incubated them at high pressure incubator. So in the high pressure incubator, they did not go into meiosis. They did not keep on developing. They were frozen in early meiosis. And then when he put them in a normal atmospheric pressure, they went on and developed through meiosis, and they were all gone in 20 days. And a study done a long time ago by Klaus Anderson's student, Biscoff, it was a long time ago. This study must have been 15 years ago. In mice, they found that there's immediate meiosis, of course, in the eggs and the follicles, but when they enter the ovary, if they don't get to the cortex, then they will go through meiosis and die off. And we know many of them die off before the fetus is even born. They start out with at least 6 to 8 million, and they are born with 1 to 2 million. And the ones that are retained are the ones that go all the way to the dense cortex and become the small follicles, and the big follicles disappear. So mechanical stress seems to be one of the important aspects of locking these primordial follicles so they don't just continue to go through meiosis and be disappear by the time of birth. And so there are studies that bioengineers have done all over the body showing mechanical stress accompanied with nuclear rotation is involved in the dormant state of mouse oocytes. But it's also, you can look it up in the literature and you can see that we have stem cells everywhere in our body. And the stem cells are in niches that have higher tissue pressure with nuclear rotation. So here's Hayashi's fantastic study on that. You'll see the dormant follicles have nuclear rotation, but when they're recruited towards the medulla, they stop rotating. So I'm not showing that yet. Doesn't. I don't know why it's not working. Oh, there. Okay. It didn't last as long as I wanted to show you, but there you go. You see the nuclear rotation. Nuclear rotation is in the outer cortex, and they are locked, but when they're recruited toward the medulla, they stop rotating. So I'm trying, okay, for whatever reason. Okay, so I'll get back to Teramoto's graph. which is what's interesting is when he looked at that, when he looked at that graph in pregnant women, he found that during pregnancy, the AMH does not go down. After about 3 months of pregnancy, it remains static, not right away, but after 3 months. And then it's still static for about 3 months after the delivery. And so the expected AMH on average would be 2.23 in this age woman, but really it's 2.51. And when you're dealing with 25,000 women, it's statistically significant. But this study has been done also in America by McCready in 2017. And it seems like the AMH goes, let me see here, the AMH concentrations during pregnancy and postpartum, it goes down and it doesn't go up. And then it goes up later and then it gradually goes down with age like it's supposed to. And so it's postulated, I'm having a hard time with, I'm going to have to escape. Something funny is happening with, I'm sorry, Alf. Something as funny is happening. Okay. So all that is evidence that supports the idea that tissue pressure is the trigger that controls recruitment of follicles and therefore ovarian longevity. And you'll see when the slides I'm going to show later that when the ovarian reserve goes very, very far down, at some point, the rate of follicle recruitment goes down as the ovarian reserve goes down. So at some point, you stop recruiting, really, even though you still have a few eggs left. So after ovarian cortex transplantation, a lowering of tissue pressure results in massive over-recruitment of primordial follicles until tissue pressure is restored. The purpose of the ovarian cortex is to produce dormancy in oocytes that otherwise would just continue developing and die. Dormancy of the resting follicles is the mechanism that saves ovarian longevity. During pregnancy, increased intra-abdominal pressure preserves ovarian longevity and AMH does not decline. Multiparous women stay fertile until they are in their mid-40s. This is also why the horse does not undergo menopause, because the horse ovary is almost all solid cortex. The mechanism of pressure-induced ovarian longevity is nuclear rotation and nuclear immigration of FOX3. In other words, the rotation of the nuclei may or may not cause anything other than FOX3 goes intranuclear, and when that happens, we're seeing arrest of follicle recruitment. And this is probably true of all stem cells. So now we're going to get into ovary allotransplant, my favorite new subject, but we're not leaving the subject of ovarian longevity because you'll see how that comes up even with the allotransplant. So this you may have already read about. It was published and it was published electronically in August 2024, and actually first came out in Fertility and Sterility in January of this year. And this was a case of a Turner syndrome girl who is now grown, 22 years of age, and she was a Haredi religious Jewish Orthodox girl, and they really can't, they're not allowed to do egg donation. However, according to Talmud, this is the culture and the religious view, is that if the egg is ovulated inside the woman, or if it comes from inside her, then we're not thinking about DNA. We're just thinking that it is her egg, and then it is allowed, and is no longer considered third-party reproduction. I'll show you more about that. So this is the online publication, but you can find it in print in January of 2025. So, oh, wow, okay. Okay, so it's a quick history. I might have been a little bit out of my sync here. Let me just see if this is where I want it. Yeah, okay. So all pregnancies from our ovarian transplants have been natural. No IVF is required. it's important to know that the reason for that is if they have fallopian tubes, you want to place the cortex in a position where they can get pregnant naturally, because you lose a huge amount of eggs from this over recruitment from low tissue pressure at the time of ovary transplant. So these women that have had a successful ovary transplant that lasts for ovary tissue transplant that lasts for 8 to 12 years always have a very, very low AMH. But they ovulate a follicle, they ovulate another follicle every month. And so the chance of getting pregnant with IVF is much lower because you have to just keep on doing IVF and getting maybe one egg. But the chance of getting pregnant if you're just going for natural pregnancy is very high because sooner or later, after 12 months, you're going to get pregnant, and it's just one egg at a time. And as the ovarian reserve goes down, the rate of follicle recruitment goes down. So these grafts last a long time, and that's why we want them to get pregnant naturally and hope they have fallopian tubes. So I want you to see this first leukemia patient with over.
That I wouldn't be cured of this. Once I found out, I just made up my mind, that's it. You just have to keep taking it one day at a time and just keep that positive attitude and know that I can do this. I'll get through it.
This goes back a long way.
It's 8 o'clock in the morning, July 17th, 1997. We're at St. Luke's Hospital. And we're about to do the first case in the St. Louis area of ovarian tissue freezing. Okay, well, I'm Dr. Silber, Sherman Silber, the Infertility Center of St. Louis, and we really have a treat right now. This is Jennifer, who at 24 years of age, I'm right on that, yes, came down with a terrible case of leukemia. They thought she was going to die, but just to be safe, in case she lived, when she did, and was cured, we would freeze her ovarian tissue. So that was like 20 years ago. And this is the first case that we ever did. And we're the only ones right now really actively with a program in the whole United States. And it's been a long time. And we didn't know that we'd be able to transplant the tissue back. And we didn't know if we could culture the tissue. And here she is now. We had her on Facebook Live several months ago. And she was happily pregnant. And now look what we have. Now she's 44 years old, if I can reveal that, with a 24-year-old ovary and beautiful baby. What's her name again?
Madeline Grace.
Madeline Grace.
So just to review, everybody knows this, but I'll review it. She had a really great ovarian reserve, despite the fact that she had already been through her initial round of leukemia treatment and was in remission. But of course, we knew she'd eventually need a bone marrow transplant, and she needed 2 of them. So this is when we got her tissue, and every time they looked at any of the tissue, they couldn't find with any markers any trace of leukemic cells. And this is what the tissue looks like, of course. And remember the other slide I showed, and you can even see it here, that the outer cortex is tougher tissue, and as you go more inside, you get lesser and lesser density, and that's what regulates. And these are the pictures from, we published this in the New England Journal of Medicine. And again, this is the same thing, that grafts last for 8 to 12 years or more. And why? I mean, they have such a low AMH after that initial rise in AMH is pretty high for just a graft that represents, say, 1/4 of the ovary tissue. And we have plenty of remaining extra frozen tissue. There they are with our baby, and it was a normal vaginal delivery. If you were going to do IVF on her, you'd be trying to get 1 egg every time. This way, she just got pregnant naturally. And there, we actually then transplanted frozen tissue to her later. And this is a dramatic picture showing her with their baby from the fresh transplant and pregnant from the frozen transplant tissue. This is another interesting case. Crystal's eggs were quite fertile until 46 years of age. We didn't know that. Bonnie was born with no eggs. So why? Her transplant still working at age 46, and she got pregnant at age 46 naturally without IVF. And this is a nurse, an oncology nurse, who had 4 babies from ovary frozen at age 19 before 2 bone marrow transplants. This is our first leukemia case who had tissue frozen at 15 years of age and now has 6 babies from her first graft. Now she's Orthodox and they just have lots of babies, one after another, 6 babies, and she still has that first graft functioning despite a very low AMH. That's the case with all of them. And our sum total from fresh ovary transplants and from frozen ovary transplants are 30 healthy babies and an average success rate of 76 or 78%. And now I add one more, 31 from the fresh allotransplant. And this is a summary slide of our results. And you can see that most of these pieces of ovary tissue are functioning for more than 10 years. And for leukemia, we even have 6 babies actually, and 1 ongoing. So there was 7 babies from leukemia actually, because that one patient has already had 6, and another has had 1, and another still has not gotten pregnant, though her ovary is still functioning very, very long term. So now it's becoming now that I meant to say infertility is becoming much wider and the world is depopulating, we need a bigger solution because so many women haven't undergone fertility preservations like the ones that I showed you there. And can we still get them pregnant? Well, I showed you that we can still get eggs out of them with minimal stimulation, but also what about just allotransplants? That is, they don't have an identical twin sister, they don't have any of their tissue frozen. What about allotransplants and even in vitro maturation? So I want to show you the first of 2 successful ovary allotransplants to Turner syndrome patients requiring immunosuppression. And this wasn't possible. We've talked about this for decades, but it wouldn't be possible unless we had an immunosuppression protocol that was shown to be extremely safe and effective. And that's where Johns Hopkins came in, originally Barnes, and Dan Brennan moved to Johns Hopkins, a protocol that emphasizes minimal steroid, because steroid is the bad agent in transplant immunosuppression. And the program, a protocol that would be safe, because we're not going to want to have any complications from women that are doing this for non-life-saving procedures. And that's what they came up with, and we decided to go ahead and use it with a 3-way collaboration with us at St. Luke's and with the Barnes team and with the Johns Hopkins team. So this is the case number 1 that I showed you the paper on. And the question was to determine whether we can safely transplant ovary tissue allograft from a non-identical donor to her Turner syndrome sister, and it was quite successful, and you'll see why. Never been accomplished between non-identical donor to her Turner syndrome sister or cousin. And for some religions, donor eggs are not allowed. However, donor ovary transplant could be allowed because the egg is ovulated inside the recipient and IVF is not required. Virtually all Turner women would prefer normal hormone function anyway, with no HRT, and would prefer to get pregnant naturally with intercourse rather than with donor egg IVF. They all prefer that. So it is easier emotionally to feel normal and not to have to tell a future mate that she cannot have children without donor egg IVF if she's really functioning normally anyway. This is particularly true in this Orthodox Haredi population, though I think it's true for secular women also. It's a difficult thing to say to a possible future partner, well, I can't have children unless we do donor egg IVF. Well, it's easier if you just have a normal ovary that's functioning. So this is a 20-year-old woman with non-mosaic exoturners who is amenorrheic with an AMH of 0.015, FSH of 67. And I'll continue, but tell me when I should stop and we'll have questions and answers, okay? So she had a 22-year-old sister who already had 2 children, normal menses, and an AMH of 4.97. They had a perfect HLA match, but they were ABO incompatible. Now, ABO incompatibility is an absolute contraindication to solid tissue or solid organ transplantation. And so we weren't going to do her. But Dan Brennan from Johns Hopkins said, let's just try it. Maybe it'll work. We don't know. And the parents and the patient were willing to go for it because they had no other choice. So they were HLA compatible, but ABO incompatible. This would prevent revascularization. There were no other donors available. It's an absolute contraindication to solid tissue transplant. And our transplant immunologists were negative about it, but decided we should give it a try anyway. So first, what we did is collect GV oocytes from cortical dissection of the 1/3 of the ovary that was going to be transplanted. This is important because we wanted to be able to use IVM to make available to her also as a backup situation to make available metaphase 2 oocytes because we weren't going to do stimulation and retrieve eggs simply because the eggs had to come from the ovary inside her. So we'll get to that. We free up the medullary tissue and thin this out as much as we can. And you can see all the little divots where there are follicles. And this will just be some videos. We show the procedure. And this is on the Kerner's cortex, streak cortex. We're just cutting off the outer tissue, the outer peritoneum, because we want to always transplant the cortex onto the old ovary if we can, so we know it's in the perfect position for egg pickup from the fallopian tube. And we then trim the cortical graft down to size so it'll fit into this area that we've opened up. And then we suture with 9-0 nylon, and we're constantly irrigating with heparinized saline. The reason for this is we don't want adhesions. We want to have absolutely zero adhesion. So we're constantly irrigating with pulsatile heparinized saline, and we're putting in stitches so tiny that we hope they will not form adhesions and will not allow any problems with egg pickup. And there you can see we've got perfect hemostasis on the medulla, and we've sutured the top part, and now we're going to suture the lower part. And this looks big under the operating microscope, but these are really tiny stitches that aren't going to be causing or interfering with adhesions. And notice that the fallopian tube is designed, the position so that the fallopian tube, the fimbria, can reach any area of that cortex whenever the ovulation occurs. And this is crucial if you want to have a very high success rate. So the immunosuppression protocol is very, very important. And by the way, this is being recorded, so you can get this anytime. So for induction, we do use a reasonably high dose of methylprednisolone, infusing 1/2 hour before the ATG. But that's all she's going to get of any kind of high prednisone. And then she gets anti-thymocyte globulin, 3 milligrams per kilogram IV over the next 6 to 12 hours during surgery. This is all happening during surgery. After the surgery, she's on tacrolimus for maintenance, and we monitor it carefully so that the level doesn't go too high. And she's on azathioprine because CellCept would be highly fetal toxic. And then for some stupid reason we can't really explain, we do put her on a homeopathic dose of prednisone 5 milligrams a day. Now, if we think there's rejection, we don't give her a prednisone burst. We're not going to do anything like that because prednisone is the dangerous drug with immunosuppression. The other drugs we're giving are safe. And you can see it takes usually about 6 months for the infantile uterus of the Turner's patient under estrogen stimulation, which not stimulation, just she had just normal hormones to become normal. So it took 4.5 months for her to start menstruating and have regular cycles and have estrogen. And then 6 months later, so that's 10 months later, her uterus is perfectly normal. So it takes that long before you can expect a spontaneous pregnancy. And you can notice that her graph of FSH and AMH is absolutely the same as all of our previous cases. It's just amazingly repeatable. So somewhere around 4 or 5 months, the FSH, which is in red, comes down to normal, and the AMH goes way above normal, and then the AMH goes down to very low levels and stays at very low levels, and it'll do that for the next 8 to 12 years. And so they can have one baby after another, like the patient I showed you that had leukemia, where the first graft, not even the second or third graft, the first graft has already produced 6 babies. So here was her fetal heart at 156 at 7 weeks. And that's her normal pregnancy at 33 weeks. That's the baby delivered at 40 weeks and 2 days, healthy baby girl. She's growing up very nicely. Cute as can be, completely normal. And so now we sort of modify our graph showing we're at 78% pregnancy rate, frozen or fresh if you include that allotransplant. The donor, are we hurting the donor by taking her ovary out? Well, her FSH was 6.8, unchanged from pre-op. She continued menstruating normally, and she became pregnant spontaneously and delivered her third child, despite having an IUD in place, by the way, by 6 months post-op. And we were confident that would happen because of the study that came out from Japan, Yasui et al., that with somewhere around 21,000 women that were followed from when they had their unilateral oophorectomy, that the age of menopause averaged 49.5 years instead of the average in the control population of 51 years. So there is this compensation that occurs that the lower the ovarian reserve, the lower the rate of primordial follicle recruitment. It's a compensatory mechanism, so losing one ovary has been shown not to reduce fertility unless there's disease somewhere. So we reported the first successful allogeneic ovary transplant with safe immunosuppression, and it's fascinating that ABO incompatibility did not cause rejection. So we will speculate from that the ovary tissue graft can survive on diffusion alone without neovascularization. And allogeneic transplantation can be formed with safe immunosuppression, and normal hormone function obviates the need for HRT in these women, and they love that. And from subsequent allotransplants, we're learning even more, and I'll tell you about that. First place, there's an extra benefit of this. So we always do IVM. In the last few years, since Klaus Anderson gave this talk at one of our meetings, advocating this, and we've been doing IVM, and it's remarkably simple to do. Anybody can do this. It's not very complicated. And Hayashi is the one that worked this out for us. Hayashi made the point that the primordial follicles in vivo are locked, and we all know that, and they're gradually released over time. But in vitro, there are 3 different stages. There's in vitro development stage, IVD, in which there's no hormonal sensitivity whatsoever. And then there's the IVG phase, which is in vitro gonadotropin stage, where the oocytes, the GVs, finally become sensitive gonadotropin after that 4 or 5 months in the human and 3 weeks in the mouse of development. And then finally, you have 1 day or 2 days for in vitro maturation. But if you take that and look at that in a human graph, you have a gonadotropin insensitive phase for 4 months after primordial follicle recruitment. And then after 11 days of IVG, that is a gonadotropin exposure, which is true in most animals. It's really quite amazing in the mouse and the rat and rabbit. In most animals, they require approximately 11 days of gonadotropin exposure to be capable or competent for the final meiotic division. And but after that, they become post-mature and degenerate. We know that. So if we compute that, 4 out of 11 or 12 days in vivo correlates with a 35% possible maturation rate, because at any given time in the woman's ovary, all those eggs, they're either going to be insensitive and not useful at all, or they will have had somewhere between 1 and 11 days exposure or more to gonadotropin. And if they've had 11 days exposure, if they've had 7 to 11 days of exposure to gonadotropin, that's the sweet spot where they have to have more than 7 days and less than 11 days or less than 12 days of exposure to gonadotropin, and then they can mature. And it's automatic because meiotic competence for IVM has already been accomplished in vivo. And you don't have to do anything to help that. You can try. There are a lot of studies. Maybe we can improve that. But you probably can improve it. But if you do nothing to improve it, 35% approximately of oocytes should mature in vitro IVM with exposure to HCG. And in our first 26 cases, you can see that it varies a lot, but there's an average of 35, well, in this case, 36% with us of GVs that you get from the dissected tissue that are capable to become mature M2 oocytes. And Vuong, by the way, in Vietnam, who's a real leader on this, has shown that the success rate with IVF with these kinds of eggs are over 60%. But if they've had prior chemotherapy or they're prepubertal, we have 31 cases like that. We haven't had any success whatsoever. So it just verifies that in vivo natural exposure to gonadotropin of 7 to 11 days is crucial for meiotic competence with HCG. And you don't have to do anything. So we get the GV oocytes from cortical dissection, and we look at the spent media. And by the way, this pathology slide is very instructive for how we can get all these eggs. Now, okay, the Vietnamese have figured out how to do this with needle now. That was very recent, but before they had published that, you can see that when you do a dissection for ovary transplant, there are going to be the eggs stuck in the outer cortex, the primordial follicles, that you want to keep there. But on the inner surface of that are going to be developing germinal vesicles. And just by dissection, rather than with a needle, you're going to be able to get a lot of these GVs in the spent media. And you can, sorry, I'm going to have to, my phone rang, and I'm going to say that, and I'm going to turn on it. I didn't think it would ring. I apologize for that. It's from my office. So you can see here, you can see 3 normal metaphase 2. You see 1 degenerated and 1 just GV, or it's actually metaphase 1, but it didn't develop. And, well, wait a second. Let me get to this. Okay. And case 2 is going to be interesting, but I don't think we have real time for that. I'll just make sure we do this slide because I'm at 45 minutes, and we can talk about all these other cases later, which really mean a lot. And we can even talk about in vitro gametogenesis, which is related to all this. So there are 3 big problems with case 2. This was a Turner's syndrome woman whose sister wanted to donate, but it was only a half HLA mismatch. So we didn't know. Maybe it would reject. Also, the donor had low ovarian reserve. Fallopian tubes and ovary had been removed from the Turner's patient. I don't know why. So that means we would need a peritoneal window and then IVF. It would be allowed in their religion to do IVF as long as we were retrieving the eggs from an ovary that was inside the recipient woman who is infertile. And we can do IVF with her as long as that ovary was now her ovary. And by Talmudic law, it's now her ovary. And so you can see she was ABO compatible, but a half HLA mismatch. And I'm going to close here for right now. We can continue. But so you don't wonder where I'm going is we found that with complete HLA mismatch, we still get successful results and we don't get rejection with this protocol. And we're even now doing unrelated, completely unrelated transplants from friends of the family to Turner syndrome patients. And The data from thousands of kidney transplants shows that with this protocol, we should still get 85% survival with no rejection. So this opens up a gigantic window for women who never had fertility preservation to recover fertility, and for Turner syndrome women, because even if they're not related, we can have an ovary tissue bank. And if when we freeze the ovary tissue, we satisfy FDA requirements so that they're eligible in terms of infectious disease testing, we can make huge ovary tissue banks that will be available to help women that never had a chance before their cancer treatment to have fertility preservation. So I'll close with that so we can have some time for questions. And there's more coming at some later date, maybe a year from now or half a year from now. Thank you very much for inviting me, and I'm open to any questions.
Thank you so much, Dr. Silber, for that very thought-provoking presentation. I just love watching your patient stories. It brings such joy. Do we have any questions from our audience? I see a question in the chat. How do you evaluate for rejection?
Well, it's really tough. It's not like the uterus where you could do a cervical biopsy or something like that. So I'm going to get to that in one of the later patients, but Dr. Brennan from Johns Hopkins has developed an HLA tissue screen, antibody screen. And so we'll do an antibody screen on them. And it's amazing, women that we were worried because they went more than 4 months and we did the antibody screen on them, didn't show any sign of rejection. And then before you knew it, they started menstruating and they didn't reject. So we think that, and it's very complicated. He set it up. We should talk to him about this and Rowena about it. But I know they send the kit to the patients and they just do this kit and bring it to the lab or send it back to Johns Hopkins and they can do an antibody screen and know if there's any rejection.
Perfect, wonderful. Another question, please brief about in vitro maturation, prerequisites and detailed procedure in short.
I'll try to be short about it, and I can get into more detail at another talk. But, there are approaches and speculations to making it maybe even more robust than it is. But without doing anything, you'll get a 35% success rate because all you have to do is get those GVs. Because the ovary, the follicles, after primordial follicle recruitment, there are 4.5 months development in the human and 3 weeks in the mouse, which is totally inert. I mean, you can't give any hormones of any gonadotropic sensitivity. But after that 3 weeks in the mouse or 4.5 months in the human, the GVs emerge from that insensitive phase and become sensitive gonadotropin. And at any one time in the ovary, there are eggs that have been exposed for various numbers of days to gonadotropin. And the ones that have been exposed for 7 days or longer, or 11 or days or less, they're the ones that are going to be responsive to HCG. And that was discovered by in vitro gametogenesis using oocytes that Hayashi manufactured in the mouse. And in other animals, it works the same. He's even done the rhinoceros. It works the same in all animals. There is an 11-day usual period that with in vitro gametogenesis, you want to expose those oocytes to gonadotropin and then finally an HCG. So applying that to the human, you can predict that at any given time in any woman's life, 35% of the GVs that you get out of her ovary during the dissection should be able to mature on their own because they've been already made meiotically competent by in vivo exposure to gonadotropin.
Wonderful. And then Dr. Silber, would you be able to stop sharing your slides so we can see you better on the screen during the webinar?
Okay, I'll stop share, right.
Okay,
Okay.
perfect. So great.
Wow, there's a lot of people.
There's a lot more people. Yeah,
Thank you for showing up.
great. Do we have any more questions from the chat or from the group? Otherwise, I have a question. A lot of us that do fertility preservation, we're finding ourselves in the position where more and more patients are coming back for the ovarian transplantation after having frozen tissue. What are some of your suggestions for like best practices for transplanting the tissue?
Well, that's really, I'm glad you asked that question because I really think that's key. You know, people talk about 30% success with baby rate or 40%, and really you should be able to get over 75% success rate, but not with IVF. IVF is really a pain because what you may not realize is you do a beautiful transplant and the vast majority of the eggs are over-recruited because of that low tissue pressure. Some people think it's from ischemia. I don't think it's from ischemia. I think it's from over recruitment. And so that by the time you're 4.5 months post-op and the ovary is actually showing signs of functioning, you have AMHs that are very, very low, really. I mean, it goes up temporarily, but then goes down again. The reason it goes up 4.5 months later is those were oocytes that were recruited 4.5 months ago after we lost so many. But then it goes down because you lose that reserve pool. And so they'll go for 8 to 12 years, menstruating for 8 to 12 years, but with an extremely low AMH. So when you do IVF, the typical mistake is to pound them with high doses of gonadotropin, and really you just want to give them a very low dose of gonadotropin to try to, and maybe even a natural cycle. But they will be ovulating every month, one egg. And you wouldn't know unless you checked the AMH and did an ultrasound. You wouldn't really know that they were so deficient in eggs because their ovarian reserve is so low that the rate of follicle recruitment is low also. So I think the best strategy is hopefully they have fallopian tubes and they don't have adhesions, and you just transplant that tissue to the dead ovary they've already got, or at least to an area in the peritoneum where you know that the fallopian tube can easily reach it at the time of ovulation. This is such an amazing thing in normal physiology that quiet-looking fimbria comes to life like an octopus when you ovulate and slams itself right over the area of ovulation and picks up that egg with its cilia. I mean, to me, that is one of the most fascinating normal physiologic events in all the world of biology. And all you have to do is just make sure that ovarian tissue is within reach of the fallopian tube. We found when we did tubal reversals many, many years ago, if you did a perfect reversal, but the remaining tubal length was too short to allow it to reach the ovarian surface, they never got pregnant. You had to be able to have a long enough fallopian tube that fimbria could come around and just plaster itself on top of the area of ovulation and pick up the egg. So I think you want to do it in such a way that they'll get pregnant naturally. The other thing I recommend to avoid adhesions is not so much some kind of a adhesive anti-adhesion graft, but rather just continuously irrigate. Have your assistant continuously irrigate with heparinized saline. You won't get any adhesions that way. I think it's a better way to do it. And I would use really tiny suture, like 8 or 9 nylon. Nylon is non-reactive. And just to make sure that you don't have great big, 3 vicral sutures that are causing irritation and might prevent ovum pickup. I think it's a very simple thing to do, really. This is not tricky microsurgery. It's not an anastomosis. It's not anything really difficult to do. You just really want to do it. I don't think you can do this that successfully with a laparoscope, but I think for most young women, a mini lap is just fine. Make a small mini lap incision and then injected after surgery with toradol, morphine, and ropivacaine, and they have 2 or 3 days of anesthesia and the incision, and it's not really very painful. You could try to call it moderately invasive surgery rather than minimally invasive, but I think you really need to do it with a mini lap rather than with laparoscope, unless you're so good with the laparoscope you can use 8 or 9 nylon.
Oh, great. Thank you. We have a couple more questions in the chat. One is, can we get anything from the ovarian cortex of a postmenopausal woman? Have you tried that, I guess?
Yeah, we tried that, and it's very tricky. Theoretically, you should be able to just remove the pressure from by taking out the ovarian cortex and cutting it up into pieces, and then even putting it back, and then you should get primordial follicle recruitment where you never got it before. That's what Kawamura reported. He found out later that the incubation to deal with P10 and the hippo complex really didn't mean anything. It was just the fragmentation of the tissue, and I don't think he's doing that anymore. I think if it's going to work, it's got to work in younger women who have had premature menopause. However, I got this advice from Zev Rosenwax. He didn't really know the physiology of this the way we know it today, but it was at least 15 years ago. He talked about some patients he had that were clearly young women with premature menopause with undetectable AMH. And they just did ultrasounds or estrogens on them every week, and all of a sudden the follicle would appear. And they were young enough that he got good eggs, just like I showed you in our first patient. And I don't know that he knew exactly why that occurred now that we know about tissue pressure and about the relationship of primordial follicle recruitment to ovarian ovarian reserve. However, it is really clear that these younger women, and I'm going to show you another case of it. These younger women can have oocytes that are trapped in the ovary and they're not being recruited, and they're still good oocytes, but you don't have to do surgery, and you don't have. I hate to say that to surgery-oriented people like me, but you don't have to do surgery. I think you can just tease them out with minimal stimulation, or if you want, just be very patient and do natural cycle and just keep checking their E2 maybe twice a month and see when it goes up and be ready for it. But I prefer doing a minimal stimulation. You have a little more control and you're less likely to lose it when you don't even know you're losing it. But there will be eggs in many women with premature ovarian failure that have undetectable AMH. I'm absolutely certain of that from our experience now. But I don't think surgery is the answer for it.
Okay, great. We are out of time, but there were a couple more questions. Couple of them are very similar. Do you offer any transformative training programs in IVM or ovarian tissue transplantation? So there's a couple questions about training programs.
Well, I'm glad you asked that. So I'm an enigma. We're a very unusual place. We're not in an academic center. However, the way we've always done this, ever since we developed microsurgical vasectomy reversal in 1973, we invite anybody to come, and they can just tail us, and we can show them what to do. We don't charge for it. And we had to move from the hospital to our own lab now in a surgery center. So I shouldn't say it, but I think it's going to be pretty easy for us to actually set up training even using cow ovaries. They're just like human ovaries, and actually do that even in our office with liquid nitrogen, and teach them how to dissect ovary tissue if they don't know how to dissect ovary tissue. They can watch us do it in real life when we have the cases come up, but I think in a more intensive way, we can just set this up. We haven't done this in a few years since we had to move from St. Luke's, but this is an easy thing to do, to set up a little workshop. And we're not going to use human ovaries for that, but cow ovaries are just as good.
Okay, wonderful. Thank you so much. Well, it looks like we are out of time, but we want to thank everyone for your participation. And Dr. Silber, thank you so much for this wonderful webinar. I've learned so much. I know the rest of the audience has as well. Thank you.
Well, that's a great compliment coming from you, Mindy, because I think you've done spectacular things, and so I appreciate your compliment.